Good morning. So DVD definitely intriguing, but when it comes to clinical evaluation, particularly the measurement, it becomes a challenge, as already told by Divya. It becomes a challenge even to the trained practitioner. So history wise, the condition usually manifests by 2 to 3 years of age, mostly asymptomatic, picked up by an ophthalmologist. Parents may report a complaint of having the child's eye wandering up once in a while. Some patients may definitely give a history of diplopia. Most of the times, it is a matter of cosmetic concern. The condition is intermittent, precipitated by fatigue, daydreaming, or visual inattention. Usually seen in association with strabismus or a surgery for the same, could be seen in association with nystagmus and amblyopia. Probe into a family history of a similar illness, and it is always good to go for a familial album tomography scan. So we initiate the examination with age-appropriate methods of visual acuity assessment, and demonstration of an asymmetric optokinetic nystagmus can predict the chances of developing DVD in future. Cycloplegic refraction is mandatory because it has been found that about 3.4% cases of accommodative esotropia have DVD as an association. And it is important to rule out amblyopia because profound amblyopia is seen in unilateral DVD. Simultaneously, you can go ahead with a fundus examination also, which helps to pick up torsional abnormalities suggestive of oblique dysfunction. So it is crucial to pick all these things because this helps us to decide whether a unilateral or a bilateral surgery has to be performed, and also tells us whether you can also help to modify your surgical procedure. Like if there is any oblique dysfunction, you may have to modify your procedure to inferior oblique anteronasal transposition or inferior oblique anterior transposition when there is an associated DVD. Now you go ahead with your sensory evaluation. Worth 4 dot test will demonstrate poor fusion, sometimes suppression is present, and tests for stereopsis usually show lower grades of stereo acuity, the exception being primary DVD, where there will not be any other associated horizontal deviation, or there will not be a history of a prior squint surgery. Primary DVD has been shown to have better stereo acuity. So measurement of DVD is characterized by its variability. It varies from person to person, time to time, the visual attention of the patient, and many a time we see that as we proceed with the examination, the values keep on changing. So anomalous head posture is a frequent correlate of DVD. It is found in nearly 23 to 35% of cases. The head is usually tilted away from the eye with the larger vertical deviation, but the other way around is also possible. Bilateral DVD is characterized by chin depression. We have this useful instrument goniometer, which is used to measure the anomalous head posture. Very important when you plan a surgery with anomalous head posture as a surgical indication. So you measure DVD first in the preferred head posture and then in the forced corrected head posture in the opposite direction. So if you see that the DVD is increasing in the second step, it should be understood that DVD is contributing to the anomalous head posture. Go ahead with the documentation of extraocular movements, versions and ductions to be documented. Simultaneously, look for overactions, grade them. Stress on the presence of overaction of inferior oblique muscles, associated V pattern, associated horizontal deviations. Look for a true hyperdeviation. Also look for nystagmus. So, Hirschberg's corneal light reflex test will demonstrate the primary position ocular deviation. Your cover, uncover, alternate cover tests need to be performed meticulously. Here we are using a Spielman's translucent occluder. You see that the non-fixating eye drifts upwards, outwards, and then slowly returns when uncovered. It is important to differentiate DVD from a true hypertropia. And while doing this, specifically check for fixation preference, because many a time post surgery in one eye, you will see that the fixation switches. Manifest and latent DVD already been told. Please remember that magnitude of the manifest DVD would be greater than that of the latent DVD. So manifest DVD, it is present, it is very obvious when the patient becomes tired, or when he is daydreaming, or when he is inattentive, fatigued, or in poor health, whereas latent DVD is demonstrated only under cover. Now, this is a very peculiar association in DVD. This is the Bielchowski's phenomenon. It is present in 50% of eyes with DVD. So here the fixing eye is presented with light of decreasing intensity, and when you focus on the right eye, you see that the eye with the DVD falls. So here light intensity can be varied using graded neutral density filters or Bergolini red filter bar. These are the special tests which we have at our disposal to quantify DVD. Most important one being the prism undercover test. So here the eye to be tested is covered with an occluder, and a base down prism of approximate strength is placed between the DVD eye and the occluder. The occluder is left there for at least 5 to 10 seconds to demonstrate or to allow for the maximum elevation to manifest itself. Now we move the occluder to the fixing eye, and the movement or the lack of it of the measured eye is recorded. And you keep on increasing the power of the base down prisms till the neutralization point is reached, when there is no further downward movement. So this is how you do a prism undercover test for quantification of dissociated vertical deviation. So the prism is placed between the occluder and the DVD eye, and then you keep the occluder there for some time. So this is a patient with a horizontal deviation as well as DVD. She is a case of bilateral DVD. The video is from Arvind Tirunelveli. Here the examiner stacks the horizontal prism along with the vertical prism and is now performing the prism undercover test. You see that there is no downward refixation shift in the left eye behind the prism. So this is a neutralized state. Now, while doing this, you can go for grading of DVD, already mentioned. This is a grading system, and when associated with a horizontal deviation, go for measurement of the larger deviation first. So at the end of PUCT, you should be able to say whether it is a comitant DVD, concomitant DVD, whether it is unilateral or bilateral. If bilateral, whether it is symmetrical or asymmetrical. So it is required to measure DVD in adduction, primary position and abduction to comment on horizontal incomitance. Many a time DVD can coexist with a true hyperdeviation. So how do you do it? How do you measure it? You measure the hypotropic refixation movement in the contralateral eye by a routine PACT with a base up prism to get the amount of the true hyperdeviation. And then you go for measurement of the total vertical drift by the PUCT. The difference between the two will give you the amount of DVD. Now, this is an interesting test which is basically used to pick up any element of dissociation, more important in identifying dissociated horizontal deviations. So, this is a reversed fixation test. Here, there is a right exotropia which is neutralized with a base in prism using prism alternate cover test. So, the right eye is neutralized, the exotropia is neutralized now. Now you shift the occluder to the left eye, ensuring that there is no movement of the right eye through the neutralizing prism. I'll play the video again. So you shift the occluder to the other eye. There is no movement in the neutralized eye. Patient fixates through the right eye through the prism for at least 5 seconds. Now you shift the occluder back to the right eye and observe the left eye for any refixation shift. If there is no refixation shift, it suggests negative reversed fixation test. Suppose there is a movement, it is suggestive of a positive reversed fixation test. So this is basically used to identify an associated dissociated horizontal deviation. Now this is a red glass test which yields peculiar results with DVD. The test essentially involves placement of a red filter in front of either of the eyes, and the patient is instructed to report the positioning of the red image. In the case of a true hyperdeviation, the below images would be the response given by the patient. In the case of a red filter being placed in front of the hyperdeviated eye, the patient will report seeing the red image below the white image and vice versa. Whereas in DVD, irrespective of the eye in front of which the red glass is placed, patient always will report seeing the red image below the white images. So that is a red filter test. And we have this Posner maneuver. Here, one eye is occluded with a translucent occluder, and we see that the eye is getting elevated under the occluder. After some time, the other eye is occluded with a second occluder, and then you note the depression of the first eye under cover. See, the right eye is coming down. Now, these are the different miscellaneous tests which we have at our disposal: VEP, MRI, magnetic search, scleral search coils, and electromyography. So, this is in a nutshell how we go about with the case of DVD. Thank you very much.